Thanks. So we're going to talk a little bit about quality and performance improvement. Now, many people think those are the same things. So let me just start off at the very beginning and say quality and performance improvement are really distinctly different. Quality is looking at how you improve your outcomes. Performance improvement is how you do those outcomes. How do you look at the entire system in which the activities are occurring that give you those results? And then how do you make a difference so that you impact your results by improving the processes that are involved in getting you there in the first place? And then we'll just mention a little bit about implementation science is then how do you put those performance improvement activities in place? So it's really an entire a process. So we'll talk a little bit about quality and really performance improvement as a research strategy, talk about some of the design approaches, and then just really briefly introduce the role that implementation science has in this. So when we look at the whole process of performing research, we have the traditional research methods that Dr. Pirani just talked about. And then we move to, well, what is it that we need to improve to either improve our outcomes or make the methods that we are using to achieve those outcomes better? How do we end up with a better approach or a better result? And then implementation science is that when we take what we have learned and apply it, so then our results are repeatable, they are reliable, they are reproducible in a way that enables us to have some consistency. So the whole process starts with how do we identify a problem? Is it a problem with our outcome? Is it a problem with the way we are approaching the performance of the study so that we can then end up with a correction to whatever has been our what we have identified? So the way that I look at this, and it's very circular in its process, and when we are thinking about performance improvement, clearly we can never achieve perfection, but we can continue to inch closer and closer by constantly evaluating what we are doing and then trying to find the defects or the areas in the process that are problematic for us. Thank you. And then improving those incrementally. One of the biggest mistakes that we make in performance improvement is that we apply a bunch of interventions all at the same time, so we never really know the effect of any of those. So we have to have a methodology and sometimes a kind of a structured or sometimes rigid process in looking at performance improvement so that we have the problem that we have identified with the research. Now we're going to start asking, how did that problem occur? What were the circumstances? Where did it happen? It could be physical location or where along the process of the either research or identification of the outcomes. Who was involved? It could be the patient or the individual that we are studying, or it could be could be the people that are involved in the performance or impacting then the application of that research. When it occurred and why it occurred are all elements in understanding then the process. So when we look at performance improvement, and I know many people will still talk about quality improvement, but we have to be very clear about what we're looking at. So I'm going to focus on performance improvement, and that is the actual steps or the methods that have occurred that have given us the results. So we're going to look at how we can improve our performance in either performing the research or improving with respect to the results. So if we look at performance improvement, then we're really focusing on how we can enhance care, safe, timely, efficient, effective methods of care. Now, in patient care or in healthcare, we think about that care might be focusing totally on the patient. But when we're involved in the clinical research side, the care can be the performance of the actual process itself. And one of the aspects about performance improvement is recognizing that we are trying to improve at a systems level. That performance improvement oftentimes does not necessarily focus on the individual. So when we think about an individual as part of the performance of an activity, if something doesn't go right, it's usually for one of two reasons. Either that individual they will not do what needs to be done. And if so, you handle that really differently, right? Or they can't. And so performance improvement really looks at what is it about the system that is preventing the individual from being able to perform at the level that is needed to give us the best outcomes? Therefore, we're not looking at whether or not that person can they physically do this, but we're looking at the system to see what is it about the performance of that activity within a system that is causing the lack of success. So we look at the way that the research or the activity is being performed, and that we try to figure out what needs to change so that the operational aspect of that research can be changed or addressed. And so we want to, at the end of the day, be able to apply what the evidence shows us as a best practice. How can we implement best practice? What are the barriers or the gaps that are preventing us to do that? So we're looking at how we take the results from traditional research and then apply those into practice so that we are, again, getting back to that so what factor. It is clear that if we perform research and we don't think about how we're going to implement that, then we fail to give life to the research that has happened, and it in many respects makes our research meaningless. If we think about implementation research, so we're not going to focus on, because that's a whole different body of study in and of itself. But implementation research is the goal is to improve the quality of care, and it's really how we integrate activities into day-to-day care. So how do we take then what we have improved with performance and then make it happen in a way that it can happen over and over and over again. The focus is on the organization as well as the provider and the system, and it, again, puts quality improvement into action. So if we go back and then we kind of take that step back into, well, what does that mean then when we are trying to improve performance and improve our methodology? The typical approaches to quality or performance improvement research is experimentation. So we're going to try to rapidly introduce then changes so that we can see what works. So we have a single intervention that we implement, we measure it, we see if it worked, and then kind of get in and get out very quickly. We ask ourselves, what's going to happen to our desired result if we do something? If we perform a particular intervention or change or introduce something differently. So we want to look at a very specific intervention and a very specific impact on that intervention. So I want to try to set up the example then between traditional clinical research and then what this means to performance improvement. So I just want to throw out the example that we have vaccine efficacy. We have a high-dose flu vaccine that we have now that's available. There was a very rigid clinical trial that was performed, a multi-year study looking at and comparing the standard flu vaccine with high-dose flu vaccine, went across 2 influenza seasons, 25,000 human subjects in that targeted population of 65 and older. They were randomized to receive one of the 2 vaccines. The primary outcome measure was looking to see the presence of culture-confirmed or PCR-confirmed influenza. And the result that was in the New England Journal article said that, okay, high-dose flu, 24.2% more effective than a standard dose in preventing influenza in that population. So this was the actual result. So if we're looking at performance improvement, what are we going to do with this particular study? What would you think? What would be an improvement activity that could be associated with this study? Well, it's really going to be, how do we get this study then into the population? We're going to give meaning, we're going to give life to this study by saying, okay, if we know that this will improve the outcome in this population, then how do we make it happen? So it's kind of like the ultimate in the Larry the Cable Guy approach. How are we going to get her done? How are we going to take this and actually make it happen in the study? So from a quality improvement perspective, we're looking at, well, what happened? Well, what happened was that we could see that if we can get this into the population, then we can affect then the outcome of that targeted age group. Now, what to do is the performance improvement or the approach from a quality perspective will be, how do we identify how often it currently happens? So what is our existing practice? And then move toward what the ideal practice will be. And that is, how do we make sure that this is available or accessible or provided to the targeted population. So the improvement will be, how do we make this happen into clinical practice? And then we can go on then to give life to additional studies that we can see, well, now, what happens to not only this population, but what is the effect on the general population if we are able to reduce disease in that 65 and over population? So it kind of gives rise then to both a quality perspective as well as new ideas for clinical research. So to make this happen, then, we have to think, well, this would be easy. Just go out and say, give the vaccine to this population. But we know that that isn't the way that performance improvement happens, right? Because we know that there are a number of barriers in a system that will keep this from occurring. So there are traditional methodologies for performing performance improvement activities. And that is a very simple approach to let's look at what is currently happening. So identify existing processes that have resulted in generally the correct behavior, and then find out what sort of barriers are present that can be corrected so we can continue to improve. So we plan. We look to see what is currently present, what might be available to change, and then we do it. Then we try, then we test what some of our hypotheses, or we test some of our sample interventions. And then we study. We look to see what the effect was. So what happened when we made this change, when we implemented this change? And then we act by saying, all right, let's take those, put those into place, and then start that reevaluation process all over again. So those of us that deal with clinical research, and we have a protocol. We have a data collection form, and we're identifying in the data collection form that something is not occurring. We plan by saying, how do we make that correction? We come up with a method to correct that. We implement it. We see, did we get the desired results? And if so, then we know that particular intervention worked, and then we can move on to another aspect of improvement. The idea with plan, do, study, act in quality improvement is going to be rapid cycle change. So how do we make it happen and then keep it continuous so that we don't backslide? So we have our standard. We identify what defects we have in our standard. We perform this rapid cycle change. We implement in a way so that we are less likely to backslide, so we don't implement some sort of a change that is not sustainable, that will not enable us to make those strides and then keep them moving forward. And then we identify then the next area that needs to correct. So performance improvement is never finished because we never achieve that perfection, but we continue to make those small incremental changes so we can get there. Now, one of the strategies that are commonly used is to do things called process mapping, where we look at a system and we say, all right, what are all the steps that are involved in the performance of that particular activity? So if we look at a patient care activity, we may be looking at the processes that are currently occurring when we put a central line in a patient, that we know that's fraught with all kinds of outcomes problems. Infection and is just one on the list. But our process map is going to help us then take the steps along the way so that we can know exactly what is occurring in that process and then identify areas where something goes wrong. So we can look at things such as the techniques of the inserter. How well are they able to adhere with best practice in terms of just performance of that procedure? We may then also look at, well, what happens then when we don't have the right supplies in place or the right equipment? Does that have an impact on the inserter being able to perform correctly? Or what happens then if people don't know how to care for the line and then errors occur just during the actual accessing of that device? So we look at the entire process across the complete performance to see where are our failures occurring, and then what can we do to address those. A big error that occurs oftentimes in performance improvement research is when you say, well, I think this is what happens, and that we implement then a series of interventions that are based on perception instead of based on fact. And unfortunately, one of the big aspects of performance improvements is understanding the complexities of the system. And then many times you will have graphic designers that will come together, and this is a big field now in performance improvement, where people are coming and saying, let me kind of draw out not only the process, but the system in which the process is occurring. Now, many of us that are working in multiple hospitals, we see this very clearly, don't we? That the performance or the system is different at University Hospital versus Norton Hospital versus Kosare Children's. All of those are different systems in which care is occurring. And so we can't say that we are going to take one intervention and apply that in each hospital and expect that we will get the same outcomes. Then we need to understand the system. We need to understand the culture of care that is present. We need to understand the approach and commitment on the part of administration that is present. All that helps us understand the system in which care is delivered, so that we then can understand the relationships between the system, the processes of care, and then the outcomes that result. This is why we can't say we are going to do one thing in all hospitals and expect that it will happen the same way, right? The same way in all hospitals. That doesn't work. And understanding that our failures can help us then understand how we can perform our improvements. All right, so if we do this whole plan, do, study, act model, understanding we need to know systems and processes, it helps us then understand why our approach needs to be very focused and very incremental. So we want to test one variable and then look at the effect that happens when we manipulate that one variable. So if we want to change a particular approach, we change one element at a time instead of multiple elements at a time, because then we don't know and we can't measure the effect of any of those. And it becomes very confusing for us to know what worked. And many times this is what happens, that we have a problem, we'll try to do 10 things and then see if we have an improvement. We may have an improvement, but it may not be a sustainable improvement, and then we may not know what worked and what didn't work. So looking at focus, predictability of our variation, trying to understand then what has happened in the background, so we can remove then background noise. So I'm just going to talk about just very quickly just a couple of different designs that are commonly used in performance improvement research, just kind of give you an idea about some approaches that may be useful. All right, one very basic one is a time series method, and that is we have a baseline, and then we have an intervention, and then we look and see what happened. We have to rely on the baseline, on the history as being somewhat reliable, that we've had a stable historic rate of occurrence. Then we have an intervention, and then we study the effect of that intervention. We've done that quite a lot. We do that a whole lot in infection control, where we'll say, okay, we have a particular problem. We are going to provide one intervention. Maybe we're going to change the germicide that's used and see what is the effect of a change in germicide on a particular microorganism. We have to be very careful that we don't change anything else, but that we just make one change. And you can see then in this graph that we're using a method that I think we'll talk a little bit about later, and that is statistical process control. And that how do we look at rates over time and know when the effect of our intervention has been can be associated with that one intervention, or if we have background noise that may confuse us. So using rules of statistical process control when we're measuring the outcomes is important as we look at it over time. Then we can have equivalent time series, which is it's just a repetition of traditional time series, where we do an intervention, we look at the effect, then we remove the intervention and see if we go back to baseline, and then implement the intervention again to see if we get the same results. So this is a very simple demonstration that we were looking at reduction of positive blood cultures by changing the skin disinfectant that was used, the antiseptic that was used. So we applied chlorhexidine after having a period of time of using a standard method of skin disinfection. We applied chlorhexidine. We saw the blood culture contamination rates go down. Our question was it the intervention that actually created this improvement? So we remove the intervention and go back to what was a standard approach before, saw the blood culture contamination rates then go back to what had been the historic level, implemented then the skin antiseptic again, and then saw a repeat then of the reduction in those blood culture contamination. So that just kind of gives you some confidence then that your historic rates were reliable, and then it really was that single intervention that was most likely associated with that improvement. We oftentimes, when we're looking at more complicated or the need to introduce multiple interventions very, very closely or in rapid sequence, we may use something like a multiple baseline approach. An example of this is if we're looking at the reducing errors, maybe in an electronic health record. So we're looking at reducing the error rates associated with our electronic order entry. So we look at then the first, the top example shows we're looking at lab error rates. So if we are using a traditional paper and pencil approach, then we start an electronic process, then we reduce the errors, and then we can watch that and maintain those that reduction over time. That becomes important then if we start to then bring in a radiology electronic data, electronic order entry, where we had the historic high rates of errors. We then bring in an electronic process. We see the imaging or the radiology error rate go down, and we see that this also did not impact then the laboratory error rate. So we can see one intervention did not then negatively impact an improvement that was identified previously. So we're using multiple baselines then to make sure that we are removing then associations between multiple interventions and how it may then impact or not an intervention that we have brought in previously. So this requires a lot of coordination, certainly, and a lot of control, but is more commonly used as we're looking at complex problems that require that we bring in multiple interventions in sequence. Quasi-experimental designs are something we've used for a long time in performance improvement research, and it's been typically it will be the pre-post test. Let's pre-test somebody's knowledge or somebody's performance, either provide education or make a change, and then test then their ability afterwards. So it could be knowledge, it could be just what I know, it could be can I apply my knowledge when we think more of competency assessment, and can help us then look at attitudes toward particular approaches as well. So our approach then is with performance improvement is how do we then make this sustainable? How do we make sure then that we can put it into play? And then that's where the implementation science comes in, that we will apply those measures. We look at the effect. We look at what happened before and after, and then we make sure that we are evaluating those results. And I think that it's the evaluation step that is most commonly dropped and not paid attention to quite well enough, so that we really do look to see, does what we are implementing make a difference, and is the intervention able to be sustained? We know that many improvements will occur simply when we bring attention to it. If we let somebody know what is expected, and then we share that information. So probably one of the simplest performance improvement interventions is just to have a written procedure so that people know I have 10 steps. You outline the 10 steps and you give that to them. Then that simple intervention of providing information will oftentimes result in simple improvements. Once the improvements then become more complex and that you involve a system having to apply that method within a department or within a larger setting, then it is more difficult then to have those simple interventions. But evaluating the effect is critical. We oftentimes think that if we tell someone and it works, then we're finished. If we tell someone and it didn't work, then if we tell them louder, or if we tell them, in a really mean voice with a lot of authority, that will change it. So it's important that we remember that those two rules, that the change occurs either because people, they can't or they won't. If they won't, then we need to know that, because that's probably not the person we want to work with, right? We want to help them. We want to make them happy and help them find another job, right? Because working in a system where quality counts is not going to be a place for someone to work if they won't perform at the level we need. If they can't perform at the level we need, then we investigate why. What are the barriers? And then those are the changes that we implement. So performance improvement then occurs on multiple levels. It occurs at the level of the outcome that we are trying to achieve, and it also occurs at the level of our individual performance. So when we think about the application of this becomes important for researchers, because our performance as researchers needs to be validated, as well as the achievement of those desired results, and then bringing that so what factor needs to be achieved. So multiple levels for research. With that, let me turn it over then for questions.